Obesity, in my belief, is the biggest healthcare dilemma of our day. And gastroenterologists have a unique role to play in the treatment of obesity because we are inherently, by training, internists first. We are digestive disease specialists. And finally, we are endoscopists. And the field of obesity is challenging because it is so inherently interdisciplinary. So really, we've learned a lot about how to effectively treat chronic diseases, and using a multidisciplinary team of different healthcare providers leads to better patient outcomes in design. We are looking at modeling the treatment of obesity around other chronic diseases, such as cancer therapy. And we are interested in joining partnership with the other physicians and healthcare providers in the field of endocrinology and bariatric surgery and primary care who have been active in the obesity space. The AGA, in recognizing that gastroenterologists have a unique role to play in the field of obesity, have been working on developing a program to guide gastroenterologists in the comprehensive care of the obese patient. And we have been lucky to have collaboration with several of our sister societies. The SAGES leadership, the TOS leadership, and NASPGHAN have all been collaborative in helping develop content for this program. It is geared around a multidisciplinary model of care for the recognition that obesity is a chronic disease. And it is also designed in a care pathway cycle. The cycle involves 4 stages of care: an assessment of obesity, an intensive treatment period, a maintenance period, and also a re-intensification for weight gain or inadequate response. Another thing that is inherent in the way that the AGA program is designed is that the care cycle surrounds the patient, and we are all working toward more individualization of care, both so that we engage patients and we maximize outcomes. So personalization of care and working toward establishing therapies that are targeted toward different etiologies or factors that underlie obesity is the direction that we hope to go in the future. What I think many of us have realized is that obesity is in many ways a digestive disorder, and we as gastroenterologists are already caring for these patients. They're in our clinics. We see them for reflux, for fatty liver disease, for colon cancer. The 5 largest cancers that we deal with, being esophageal, gastric, liver, pancreas, and colon, are all at increased risk in people who have obesity. So many of us want to step in and take a role at addressing this modifiable risk for so many of the gastrointestinal diseases that we treat. At the AGA, we really believe that gastroenterologists becoming more involved in the care of our obese patients will lead to better treatment, better access to obesity care, collaboration across the spectrum of obesity treatments, and be important in addressing this healthcare crisis that we face.